Ajinkya.
A very good evening to all of you. I, Dr. Ajinkya, along with my colleague Mr. Amardeep Raina and Mr. Abhijit Singh and entire Emcure family, welcome you all to today's webinar, which in association with Baroda Obstetrics and Gynecology Society. Since the beginning, women's health has been a very important aspect for Emcure, and Emcure continuously and very diligently keeps on striving to bring you programs that help in creating awareness and improvement in women's healthcare through different scientific programs. Today's program is not different than this. With this, I start the program by sharing a small video that highlights the motto of Emcure, that is success through innovation. Mr. Abhijit, you can share the video now.
Yes.
Recording in progress.
Is it visible?
No.
No, not yet.
Okay.
Thank you, Mr. Abhijit.
Thank you, Dr. Ajinkya. Please take.
After that short video, now we come to today's program in association with BOGS that will be focusing on life-saving gynecological operative procedures and anemia management. To take the proceedings of this meeting further, I now would like to take the privilege to introduce today's Master of Ceremony, Dr. Dolly Ramnani ma'am. She is the Associate Professor at GMERS Medical College, Guthrie. I now request Dolly Ramnani ma'am to take the proceedings of this meeting further. Over to you, ma'am.
Thank you, Dr. Ajinkya. Namaskar. A very good evening to one and all. On behalf of Baroda Obstetric Society, I welcome you all to the scientific CME on this lovely Saturday evening. We have two beautiful, talented divas as speakers today evening. So let us fasten our seatbelt and get ready for the power pack ride. Now, to start with, I'll introduce both the chairpersons for today's session and also the speakers. So the chairperson for the first session is Dr. Beenal Shah. She is the consultant gynecologist and laparoscopic surgeon practicing at Barkesh Hospital. She is the organizing chairperson for IMSCon 2022. She is the past president of Baroda Obstetric Society and Vadodara Menopausal Society. She has been awarded with many. She has been awarded Best Paper Awards at IAG Conference, Aurangabad. She had been the faculties at various local, national, and state level conferences. Next slide, Dr. Rajin. Yeah, so it's my pleasure to introduce Dr. Kavita Bapat, ma'am. She needs no introduction. She's the Vice President of FOXY 2021. She's the Organizing Secretary of AICOG 2022 Indore. She's the Director of Bapat Hospital Indore. She is specialist and known for one-day hysterectomy. She is ICOG Vaginal Surgery Certificate. Her center is ICOG Vaginal Surgery Certified Center. She is the peer reviewer for Jogi. She initiated the registry of primary ovarian insufficiency. She is the award winner of NICA Indore and captain of industries. She is the vice president. Just a minute.
Baskar.
Ma'am,
yeah. Thank you, Dolly. I'll take over.
Okay.
Yeah. So it's such a pleasure, Kavita ma'am, to welcome you. And बस आपके लिए एक ही चीज कहना काफी है कि मैम के नाम से इंदौर में एक चौराहा है. So like Bapat Chauraha, and I was so impressed that like the popularity of ma'am is there not only in Indore but the entire India. And I have had pleasure of working with madam when she was the breast committee chairperson. So thank you so much, ma'am, for sparing your valuable time. And I can understand that being the organizing secretary of the upcoming AICOG, you must be very busy, but still you have spared time for the Baroda Gynec doctors. So really, I'm a fan of your fabulous vaginal surgeries. So over to you, Kavita ma'am, for a very important topic, that is life-saving vaginal surgeries. So whenever life-saving comes, we always think about obstetrics, but it can be vaginal surgery as well.
Abhi surgery chal raha hai, वैसे life-saving vaginal surgeries also we can talk someday.
Yes.
Today I'm talking about life-saving surgeries, gynecological surgeries.
Yeah, sure, madam. Over to you, madam. Thank you so much.
Thank you so much for a lovely introduction. You both, Archana and Beenal, you are really a darling person. And thank you. Where the girl has gone who was introducing me, she has gone somewhere, I think. So thank you so much, Donnie, for introducing me. Let me allow to share my screen and then I'm here. That's all. I think I'm able to see my screen. So we are talking today about the emergency hysterectomies. It's a subject. Hysterectomy is basically very close to my heart, and when it can be hysterectomy, can be emergency or not emergency. It's a very important subject. And the way to get started is to quit talking and begin doing. Actually, emergency surgeries are like that. You cannot sleep sometime somewhere, and I'm being called all over Indore for last 20 years for emergency hysterectomies. लोग ये भी बुरा मानते हैं कि क्या बिना बात के कितनी hysterectomy हो गई, but this is a really needed one when it is done. So the emergency hysterectomy is basically a very life-saving procedure. It involves the surgical removal of the uterus and usually performed for uncontrollable maternal hemorrhage. This is the one and the most important indication which all talk about when all other conservative managements are failed. But nobody likes to do the emergency hysterectomy until and unless everything is going out of our control and this thing. So I just put a few words regarding the history of the peripartum hysterectomy. Was proposed in 1768 by Joseph Cavallini in animal experiments. And the first documented cesarean hysterectomy was performed in Horatio Trotter in 1869. So you can imagine so many years back it was also being done. I don't know which was the route, by opening or just cut it down from the down, I don't know what they did. but it's really important. In 1876 is performed the first cesarean hysterectomy in which both the mother and baby survive. So it is another important aspect of the things. In our old practice, I am practicing for last 32 years. And what is the incidence? Even you people like Veenal, Archana, Rashmi and Dolly can also say कि कितनी hysterectomies उन्होंने देखी हैं as a cesarean. So it's 0.004 to 15 per 1,000 deliveries, Tilland says. And American Medical Journal says it's a 0.24 to 8.7 thousand deliveries. It's American Journal. And 30 per 100,000 following the vaginal delivery and 270 per 100,000 following the cesarean section. So the rate is 270 is more with cesarean section rather in a vaginal deliveries. What are the risk factors? Which nowadays we are doing so many repeat sections, so many things. The previous section has become the #1 risk factor for the emergency hysterectomy. Then the abnormal presentation, including previa, multiple gestation is another important point. A grand multipara, fetal macrosmia, previous PPH, and coagulopathy. I am just taking out of this one risk factor. Nowadays, I am finding not simple patients come to us because of the seniority or something, a big fibroid and a pregnancy. This has become a very common with me. So I do sometimes cesarean section, and my temptation and heroic behavior of mine, most of the time I also remove the fibroid during the C-section because previously the indications used to be different, but nowadays we do myomectomy and sometimes it is in a soup. And another risk factor is a chorioamnitis. So we can classify the peripartum hysterectomy in 3 types. Sometimes it's circumstantial, it's emergency, indicated, elective. Sometimes the extent, supracervical and a total or a radical. And third is a clinical contest, sometimes in a planned cesarean birth and emergency cesarean birth. Sometimes very, very rare is the eccrita, percrita, many more things are coming nowadays and we have to do, and postpartum is another thing. With all we are talking about, uterine hemorrhage is #1, placental problems is 11%, rupture of the uterus. I think with our practices and a good medical care and a referral to the right time and institutional deliveries, I am sure that we all of us are finding uterine rupture less and less. Postpartum anatomy is a very important extension of cesarean section into uterine vessels, infection, chorioamnitis with sepsis. So another thing, but the most common incidence indication which we talk about due to increased rate of C-section, placenta eccrita, increta and percrita are becoming common. Though we do the 3 triple pre procedures, that's a perioperative location of placenta and delivery of the fetus by incision above the upper border of the placenta. We do the pelvic devascularization by inflating the radiologically pre-placed occlusion balloons of the both internal iliac arteries and placental non-separation with a myometric excision and reconstruction of the uterine wall. So these are the triple P procedures which we do in a placenta eccrita percrita things. Still, we have to do the emergency hysterectomy sometimes. Uterine atony, as I have already talked about, the postpartum hemorrhage is a constant bugbear for the obstetricians. It's a nightmare basically, and failure of the sequence of all conservative measures and relationship between the blood loss and the duration time that passes the prior the decision of the hysterectomy. So the most important when we take the decision, how much time we have given to the patient, the blood loss and the duration of the entire time. And decision making is very, very important, and possibility of the hysterectomy getting complicated. So it's a directly proportion. The longer the duration we take taking the decision, longer the more are the complication, lesser the time, lesser the complications. Again, uterine atony may be due to tissue, trauma or thrombus, and incidence reduced due to the liberal use of pharmacological treatment, because we are doing so many things and uterine atony is being treated very well. So the chances of emergency hysterectomy is less and less. So the decision making timing is critical. कब की जाए hysterectomy, क्यों की जाए, क्या-क्या documentation हो, क्या legal issues हो, so many things are there and we should consider all of them and should not be performed too early or too late. So a sequence of conservative measures should be attempted before the restoring the more radical surgical procedure. We cannot do immediately or something, and indecisiveness delays therapy and results in a fatal hemorrhage. Increased duration of time, increased likelihood that the hysterectomy will be seriously complicated by coagulopathy, severe hypovolemia, tissue hypoxia, hypothermia and acidosis, and last and most important, further compromise with the patient status. So it's very, very important doing hysterectomy, saving the patient or putting the patient into the coagulopathy, hypovolemia, tissue hypoxia, hypothermia, and so many things. ACOG recommends if the hysterectomy is performed for the uterine anatomy, there should be a documentation of the first attempting the other therapies. So most important medical legal aspect, number one is the documentation. In a most of the suspected placenta accreta, however, hysterectomy should be the primary management, especially when the woman does not desire future fertility. Not so easy to say this, ki every placenta per accreta, we cannot do the hysterectomy, but this is one of the life-saving procedure. So pre-planning is a proper consent, explain the possibility of the high-risk patients, adequate blood arrangement, prophylactic antibiotics, arrange for general anesthesia, and multidisciplinary team always needed, obstetrician, obstetric anesthetist, urologist, vascular surgeon, and interventional radiologist should be there, and appropriate instrumentation should be available. So these are the supplies for the peribarian hysterectomy. Kya hame extra lagega? Heavy clamps, Kelly's lamp, so angles, and the handheld retractors, self-retracting retractors. I'm just enumerating all those, though each and everyone knows it. But for the student, suction cannula, laparotomy packs, hemostatic agents, standard cesarean delivery instruments, multiple sutures are needed. Patient preparation, it's a stirrup if it's a vaginal delivery, and a bladder, catheter, vaginal preparation, so many things. And a patient stabilization, we need blood products, uterotonic agents, multiple large bore intravenous lines, arterial lines, warming devices, rapid blood infuser, and incubation equipments. So these are the care bundles. Nowadays, we talk about all the FIGO, all the RCOG, or the AICOG. Number one, it needs a consultant obstetrician, planned and directly supervising the delivery. Consultant anesthetist, planned and directly supervising anesthetist and delivery, blood and blood products. And multidisciplinary involvement in pre-op planning. And discussion and consent. Again and again, I am repeating, we need a good discussion, we need a good consent. And this intervention like a hysterectomy, leaving the placenta in a place, cell salvage, interventional radiology, all should be discussed. And local availability of critically care unit is very, very important when we talk about. Now we have to take help of urologist when percreta is there, and interventional radiologist if we want to put and catheter peeling. These are things. Now, what surgical pitfalls we find out when we do the cesarean hysterectomy, and it's a teaching for all the students who are doing the surgery more and more. So normal anatomy may be distorted. Vascular pedicles are thicker, more edematous. Vascular pedicles should be doubly clamped and avoid seepage of the ligature. Small pedicles should be secured and not tied when they are correct in anatomical plane, without torsion, without twisting the pedicles. So this is one of the surgical pitfall. Another surgical pitfall, bladder might be adherent to the lower segment, especially in the previous section. Presence of uterine tears, extension, uterine angles might increase the risk of ureteral injuries during the placement of the sutures, and unintended oophorectomy due to the shortening of the ovarian pedicles. So all three things are important because we see the bladder is adherent, another uterine tears, and third is the oophorectomy if being done sometimes. So ovarian pedicles are troubles. Another surgical pitfall, difficulty in identifying the cervix. Very, very important in hysterectomy is needed. Caesarean section done and a full dilatation. The tissue might be very friable and that can pose added difficulties. Great care is necessary to avoid the injury to the organs adherent to the uterus, bladder, and nexa abdominal wall. Another surgeon must be prepared and recognize and repair the injuries of urinary tract. He should know, but the surgeon should know all those things when he is doing emergency hysterectomy. So that's why we say the emergency hysterectomy being done by a very senior surgeon or senior gynecologist. Surgeon means gynecologist. And the hematomas of the broad ligament, neighboring structures make the visualization difficult and distort anatomical relation. And careful exposure. Skilled assistants are very, very important. You cannot have any assistant like anyone, and attention to the hemostasis and a primary importance. So the need of experience and a senior obstetrician, second opinion of the experienced one, and surgeries should not be delayed. Less definitive procedures with a surgeon has a little experience, should not be attempted. Now, procedure is very, very simple. The incision medial vertical, if phalansteal vertical midline is preferred in the emergency situation, hypogastric artery ligation anticipated, enter into the earliest method. Delivery is best accomplished by the classical low vertical incision, which can be made hemostatic using the towel clip and single running layer of suture. Exposure is best obtained by traction of the uterus along with the retractors, and steps are same as the abdominal hysterectomy with same procedure. Now it's very, very important to transection of the long ligament, just putting around ligament, cut it, clamp it and do it. Then tubo-ovarian ligament, similar like abdominal hysterectomy we do. Then go for the uterine, skeletalization of the uterines, clamp it, cut it and remove it. Then clamping of the cardinals, and the important thing, if the cervix is fully dilated, palpating the upper vagina, pinching and palpate the cervix, hooking the finger between the cervical rim and the vaginal wall, and through the cesarean section. This is the way we should do. Find out the lower rib and remove it. Wall repair, simple. Each lateral fornix secured, cardinal uterosacral ligaments. Achieve hemostasis by running lock of 1-0 and prefer to close the vagina using the figure of 8 catgut. Indwelling bladder drain and suction drainage. Wall closure, again simply the way we do it, we should do it. Subtotal hysterectomy is another important thing which we do. But in a stable patient, keep pedicle small, ensure and carefully doubly ligated. Engorged and edematous tissues are important. Exist following delivery can cause vessel tight with large pedicles to slip and retract. Then unstable patient, click clamping and a cutting until the bleeding is controlled, uterus is removed, pedicles are tied off and ensuring the hemostasis. But the most of the time these patients are unstable, so the fast and the quick surgery is very, very important. Total hysterectomy is the operation of choice in the cases of central placenta previa. So why subtotal or total? It's unstable patient. Sometimes we have to do the subtotal hysterectomy, finish it, removal of the cervix is not necessary. Bleeding due to the uterine atony. The advantage is less operation time, reduced hospitalization, reduced risk of bladder ureteric injury, and potential risk of malignancy in cervical stump, need for the regular cytology, and bleeding or discharge associated with residual cervical stump. So post-operative is another important point. Record the indication of the surgery, have discussion with the patient, bladder drainage for 7 to 10 days, tackle postnatal symptoms and require counseling. Complications is a febrile morbidity, blood transfusion, coagulopathy, ICU requirements, urologic injuries, and reoperation, sometimes for the intra-abdominal hemorrhage or the other damage. Incidental bladder injury, gush of a clear fluid in the operating field, repair primary. Bladder injury, we all should know how to repair it. I'm telling you, if you are a gynecologist doing operative surgeries, we should be able to report. We need not to call anyone and we should be able to do it. After conversion of the ureteral patency, bladder closure by 2-3 layers and continuous bladder drainage. Oophorectomy, due to inadvertent clamping of the ovarian ligament, sometimes do, at times to stop bleeding from the infundogalvic vessels, and 5% peripartum hysterectomies, 1 adnexa was removed to stop bleeding. It's a results. Now these are the changing trends. Increased cesarean section and placenta become a common. Hemorrhage has increased due to the increased success of treatment due to tonic agents, prostaglandins, embolization, uterine catheter, and surgical procedures, reduction in elective procedures, and downward trend incidence of uterine rupture with modern obstetrics and research. So that emergency hysterectomies is becoming less and less. Now the summary is very, very important about it. A dilemma where the decision regarding emergency hysterectomy as a last resort to save the life of the mother. It should not be the first thing that every gynecologist should do. Number 2 important tool can be made rarer by good antenatal care. Number 2, active management of labor. Number 3 is the early recognition of the complications and performance of the C-section. And 4, the triple P procedure should be given more importance so that we can save the uterus and we need not to do the emergency surgeries. A sequence of conservative measures control uterine hemorrhage should be attempted before the swiftly instituted. And another important point, indecisiveness, delay in therapy results in a possibly fatal excessive hemorrhage. So there should not be delay. then the hysterectomy will be seriously complicated by coagulopathy, hypovolemia, tissue hypoxia, hypothermia, acidosis, which further compromise patient status. And timing is critical on the optical outcome. When we perform the hysterectomy, two should be there. Now, the take-home message is emergency is a necessary evil in obstetrics, curtails the future childbearing potential of the women, and saves the life of the mother. Again, I'm sorry for this. The morbidity attributed to the indications, underlying disorders, procedure. Now, this point is very, very important. PG training in this rare skill can prove life-sparing. So I'm not saying that PG should see this type of surgeries, but at least they should see the videos, they should assess something, and they should know if necessary. So the postgraduate training for cesarean hysterectomy is very, very important. And rising rate of the cesarean section, our responsibility, multiple pregnancies, bound to increase the incidence of emergency obstetric hysterectomy in future. Thank you so much for the patient listening and given me the chance to speak today. Thank you so much. I've stopped sharing.
Yeah.
Thanks.
That was super, ma'am. Just like your fast surgery, your talk was very quick, but at the same time, it was very comprehensive. You covered almost all the aspects, starting from the promptness which is required in the decision making, the care bundle, the consent, the medico-legal aspects. So you touched everything. And the most important were the surgical pitfalls, because that is where, we have to be very careful. And you are very right that often maternal morbidity mortality is because too little is done too late. So that is what is important. And you are very right that training is required in this aspect. So thank you so much, Kavita ma'am, for your input.
Thank you so much for all.
We are looking forward to seeing you at Indore.
I know, we are there. Baroda OB-GYN Society is always great for me. I think last 10-15 years, bolo ya Pankaj Desai ki jamane se bolo. I cannot say like that. But every president of Baroda OB-GYN Society has given me a chance. So thank you so much, Beenal, darling, Archana, and the future presidents over here, jo bhi honge. So thank you so much.
Thank you so much, ma'am. I know it is very difficult to spare time, but as Beenal already said, we learned a lot. Thank you for joining us, ma'am. Thank you.
I'm there. I should be there in the whole session, and I love to listen to you.
Yeah.
Yeah. Thank you, ma'am. Do we have any question in the chat box, Dr. Ajinkya?
I think after this thing we can do it. Or
Right now we
are not having, ma'am, any question in the chat.
To all the participants, we request you to put all the questionnaire in the chat box so that we can take the questions. So after this excellent first session, now we move to the second session. Anemia is very common in the pregnant ladies. If untreated, it can lead to serious complications. So now I welcome the chairperson for the second session, Dr. May I request Dr. Rashmi Banerjee, ma'am, to chair this session. She is a consultant gynecologist at S.G. Patel Women's Hospital and Subecha Hospital. She has more than 25 years of clinical experience. She has been actively involved in SOGOG 2013-2019.
It's okay.
Mute.
Dolly.
Okay, Rashmi Banerjee, ma'am, please take over. Over to you, ma'am.
Thank you, Dolly and Archana, for today's opportunity. And it was lovely listening to you, Dr. Kavita. We'll miss meeting you at Indore because I'm not coming, but I'm sure it would be a great conference. But I'm looking forward to our dancing swan to dance her all
thank you so
way to Indore in the conference. So, like, to make it short and sweet, Archana is the president of the Baroda Obstetric Gynec Society, and a great friend and a great academician, a very bubbly and cheerful lady. I will not call her girl now. She's a lady, though I wish we are all girls still. Yeah, and over to Archana for this very important talk. And like it has been pointed out, if anemia is corrected, then even if you have to go in for any emergency life-saving surgeries, the outcomes are always good, because anemia is, one of the killer disease for obstetrics. Over to Archana.
Yeah, thank you so much, Rashmi. I'll share my screen now. First of all, it's a pleasure and honor to share the screen with Kavita ma'am, who is my mentor, and I look forward to her for everything in my life, I would say. She is a real ideal person for me. So thank you, Emcure, for introducing her again to me on this webinar after a long gap. So happy to see everybody around. So as Reshmi already said that when we talk about the iron, if the lady is being supplemented well, probably when the emergency procedure is there, we are well prepared for that. So talking about the anemia prevalence in India, it is an increasing trend. And let me tell you that when we catch them young, we are at a better position to treat them, because most of the women who are landing up into the pregnancies often are malnourished or undernourished during their adolescent period. And that is what carries forward to an anemic girl who is marrying and then finally getting pregnant with not a very compliant hemoglobin levels. So as per a recent National Family Health Survey, the prevalence has increased over last 5 years. Probably we can blame the zero figure concept also for that. People are dieting for unnecessary reasons. And here we have pregnant women. When we talk about the urban scenario, you can see that it is almost 45% here. So nonetheless, we cannot blame that this is a rural population only. So we have got a mixed type of increasing trend, which we are seeing. And the various causes, as we all know, it is nutritional deficiencies, iron, folic acid, vitamin B12. Copper is a very important element and riboflavin for the absorption and basically the transport. And hemolysis and abnormal hemoglobin synthesis, like there are various reasons, especially in Gujarat, also Panchmal district and all, where we have more sickle cell anemia. And India already is an endemic place for malaria, if we talk about. And more investigations have helped us detecting more of G6PD deficiencies. There is blood loss, there are various GI infestations, various delivery complications, which we discuss with Bapat Madam also right now. And there are certain chronic conditions, especially malignancies, tuberculosis. Again, we have endemic prevalence of tubercular patients. CKD is also increasing, and there is increased urinary tract infections also. And with more and more TV and more media hype, I think more STDs and more HIV incidents, which is seen in the youth population. And the concept of overeating and not taking good care of yourself has led to more chronic rheumatic and rheumatoid diseases. So there is the increase in prevalence, and more likely we have got more patients suffering from anemia. So when we talk about the total iron requirement, when the lady is menstruating, it is 0.8 milligram per day. When we talk about the pregnant lady, it is almost 7.5 milligram per day. So that highlights that the total iron requirement for pregnancy is more. And the average daily absorption in the Western diet is 1 to 5 milligram per day, and Indian diet it is 0.8 to 4.5 milligram per day. So total iron requirement for a singleton pregnancy remains somewhere between 1 to 2 grams according to this chart also. And whenever the lady who's coming with maternal anemia, which contributes to almost 18% of perinatal mortality and 20% of maternal mortality, which includes India in a major chunk, you can see there is so many antepartum complications when we talk about that is increased preterm deliveries, PROM, preeclampsia, suffering from IUD or intercurrent infection, which is very common, chorioamnionitis, leading to again preterm labor, antepartum hemorrhages, and congestive heart failure and cardiomyopathies. The fetal outcomes are also not of a very healthy sign. We have a low birth weight, we have premature infants, infections which are dealing with the infections, congenital malformations. There is an incidence of neonatal anemia, and the most important thing is loss or the abnormal cognitive development, more increase in autism and cognitive problems, which are on increase in India and out of all over the world, which needs to be talked about. So it is very, very important to treat and diagnose anemia. So WHO hemoglobin cutoffs, if you see in this chart, a pregnant woman anywhere between less than 11 can be termed from to under 7. Under 7 is to be termed as severe, 7 to 9.9 is moderate, and 10 to 10.9 is a pregnant woman who's suffering from mild anemia. And we talk about this group where the children 12 to 14 age. Let me tell you that when I had one survey I did in the very good corporate hospital schools from 6 to 12, it was a dismay for me that I had only one girl who had 12 hemoglobin level. and all the rest fall below 10. There were 6, 5. That was a shock to me also. We did the survey. We treated with the help of company personnel. I am glad to share that it was from Emcure, where I got the help from iron supplementation. So this is the situation what we are dealing when we're talking about the adults. And so how can we help is to catch them young and treat them at a very early phase to have a proper diagnosis, and we have less iron deficient women who are entering the pregnancy. So how to diagnose? A CBC is a very important parameter. I am not saying that I'm against doing hemoglobin itself, but when you're talking about the iron itself, CBC, when we do, we see we can diagnose thalassemia, we can diagnose vitamin B12 deficiency. Everything comes under the one head if you properly do a CBC and you learn how to read. And serum iron, total iron binding capacity is also very important, because there is a diurnal variation which is seen, also affected by the dietary influences, but pregnancy increases the total iron binding capacity in absence of iron deficiency anemia. So this is very important to do certain tests whenever you are suspecting anemia. There's importance of doing serum ferritin, because anything between less than 30 micrograms per TSC to diagnose and treat iron deficiency in pregnancy. So differential diagnosis can also be done of microcytic anemia, which is under evaluation. Suboptimal response to oral iron can be seen by testing serum ferritin. And if the patient is a known hemoglobinopathy, it is always important to do it prior to starting the iron therapy. And in non-anemic women at risk of iron depletion, where there is a history of previous anemia or multiple pregnancy, teenage pregnancy, pregnancy with high risk of bleeding and consecutive pregnancy, and preferably when we are planning to give her a parenteral iron supplementation, it is very important to do a serum ferritin level. So now coming to a very important thing which I'm trying to highlight right now is role of parenteral iron therapy in iron deficiency anemia. There are indications and there are contraindications. Initially, first trimester, we had contraindication which still prevails, but with a certain, where it is a life-saving measure, and there are certain communities which do not want to take a blood transfusion. Here we can, there's a gray zone where we can always give in that field also, or where there's a lack of facility of resuscitation because there are allergies which are reported, and when there is a known history of anaphylaxis or allergic reaction to the parenteral iron and known state of iron overload. So there we have to restrict ourselves when we are talking about parenteral iron therapy. But it is definitely indicated when there's a failure of oral iron therapy, non-compliance, or late second or third trimester with moderate to severe, because this is a zone where we can give it in adequate amount and have a proper hemoglobin levels when the lady reaches to term at the time of delivery. And there is rapid rectification and anemia, as well as there is a buildup in the store of iron also. Where there is malabsorption syndromes or bleeding diastasis when hemorrhage is likely to continue. So this IV iron therapy here becomes superior in terms of speed and getting the rectification easily. So iron agents are spheroid particles with iron core and carbohydrate cell. This is the orange thing is iron oxyhydroxide core which is there, and the shell which stabilizes the molecule and slows the release of elemental iron. So parenteral iron, we have got these preparations available in the market, that iron dextran, iron sucrose, ferric carboxymaltose, and iron isomaltosides, which is available right now. High amount of iron is single dose and low risk of hypersensitivity reaction. When we talk about carboxymaltose is a very good molecule which is available, and now it is time tested, I would say, because there are preparations iron isomaltoside also, but more labile iron and low clinical evidence still makes me prefer the ferric carboxymaltose. So the property, when we talk about the ideal with iron dextran, iron source, and ferric carboxymaltose, the time of injection is very short, and 4 to 6 hours, 20 milligram per kg, and 3.5 hours to 7 milligram per kg, 15 minutes for 1 gram of this thing. So maximum dose which you can give is high, 20 milligram per kg body weight when we talk about iron dextran, and 600 when we talk about iron sucrose. And 1 gram again, when we talk of ferric carboxymaltose, so we can give it very comfortably in the daycare procedure also, having a stable and iron which gives us the results very easily, and it is near neutral when you talk about the pH with a 16 hours half-life. And this is what gives us the preference over the other molecules which are available. So what are the critical attributes when we talk about FCM? That is, it's a parental iron which is not associated with hypersensitivity, can be administered at much higher dose structurally, which is similar to the ferritin, and it is really slowly avoids toxicity and oxidative stress. And it is a short infusion time, that is 15 minutes. So as I said, it is a day care and low immunogenic potential. There is no test dose which is needed to be done. And in the real life case scenarios, it is very clinically used with a limited time of day care for the patient with maximum availability, and also rectifies the iron stores. So when we calculate the iron requirement is based on hemoglobin and weight of the patient, that is weight upon hemoglobin, that is in most of the Indian women, 1000 to 1500 as a practical dose. If I say it is well tolerated and it's well suited. So that is the way we can give it. And when we talk about giving the 500 and the 1K, 500 should be given 100 ml solution, and 1K the 250 ml of normal saline solution. And ensure the minimum of 6 minutes for the this thing, 500 milligram, and 15 minutes for the 1K substitution. So clinical evidence, when I talk about during the pregnancy, this is a global evidence which is being seen in this chart, and there's a highest hemoglobin rise of 3.6, and Indian studies it has been seen 5.5. That is the current evidence highlights the data of FCM usage in 3821. That is quite a number in which the hemoglobin rise was seen almost 5. That is very good. And ferritin rise 180. So that gives a promising result when we talk about iron deficiency anemia treatment in the Indian scenario. These are the various Indian studies, and very convincing studies again, and with a significant rise. So inside of the largest Indian real world evidence, you can see that 271 pregnant women receiving FCN 1 gram, 1K that is, and it is a very promising results again. So significant increase in hemoglobin was noted in just 20 days. This is what we want for a short and rapid treatment. And the significant rise, almost 4 to 5 grams, was noted when we talked about the severe anemia patients. So single large dose administration with a shorter duration and achieving the result in a moderate time is what is the USP of this molecule. Adverse events reported was in just 4%, and there was no hypersensitivity reaction, and continuous monitoring of vitals and oxygen saturation up to 45 minutes did not report any negative. So it is more safe also. Absence of any hypersensitivity reaction and no negative safety signal is vital parameters observed during continuous monitoring supports the excellent safety data. And in moderate to severe anemia, in a real case scenario, which is a day in, day out, when we talk about the Indian OPD, I mean, it's a very good thing which is available now, and we should, those who are not using should start using it rampantly, because there is no adverse effect in terms of perinatal and neonatal outcome also, which was observed in newborns. This data is from 162 newborns who were born to the mothers who had received FCM in pregnancy. And this was analyzed in terms of mean gestational age at delivery and mean birth weight, Apgar score, stillbirth, perinatal and early neonatal mortality rates, and requirement of hospitalization, which is very, very important for us. So in the global study, almost 206 pregnant women treated either with FCM or iron sources. Intravenous iron treatment in pregnancy, when the comparison was done, there was no negative side effects which was seen, and in terms of the mother and maternal and the newborn. So that is a very important thing. 95% women treated with FCM with a single dose of 1K. Neonatal outcomes, weeks of pregnancy, delivery, Apgar scores, and birth weight, all were not adversely affected. So that is a very important thing, and IV iron is there to stay, and it has got a very promising result. Again, in 126 women, which was studied in the global clinical study, neonatal outcomes, it was very good. No complications were associated in terms of mothers who were treated, and almost FCM was administered in 83 pregnant women who were treated. And again, the Apgar scores were very good. The weight was good. Length and head circumference of the baby, neonatal resuscitation was same as any other population which we are treating. So it is a very prospective trial, and we should, I'm very convincing also. So Anemia Mukt Bharat guidelines, let us talk about it. And we have our Vice President Kavita Bapat Madam, an enthusiastic gynecologist who have joined us for this movement. Mild anemia, hemoglobin 10 to 10.9, and moderate anemia 7 to 9.9. 2 tablets of iron and folic acid tablet daily for 6 months. So first level of treatment, parenteral iron IV iron sucrose FCM may be considered as the first line of management in pregnant women who are detected to be anemic late in pregnancy, or at whom the compliance is likely to be very low. So those patients who are lost to follow-up, are not getting compliant, it's a very good first level treatment which is available. And if there is no improvement after first level of treatment, referral to the higher health facility. Case may be managed with IV iron sucrose and ferric carboxy maltose IV preparations which are available. Talking about the severe anemia guidelines, the first level of treatment, they should be immediately hospitalized if it's the 3rd trimester of pregnancy, where the round-the-clock specialist care is available, and treatment will be done using IV iron sucrose or ferric carboxy maltose by the medical officer. So talking about the clinical evidence of management postpartum anemia, this is a very good study, different, almost 10 studies you can see which is published, and almost the hemoglobin rise is seen between 3 to 5, which is again very promising if you give in the postpartum, immediate postpartum period where the compliance is good and the patient is still with us, to have a proper lactation in the post-operative or the post-delivery phase and a proper convalescent of the patient. So when we talk about the gynecological condition, again with iron deficiency anemia, proper time the patient has received to us, and we manage with the FCM in the clinical guidelines, as these studies say, that we have got a better iron stores, and we can always have a better outcome when we talk about the patient. I usually give, and I have got very good, excellent results. So talking about the clinical evidence in the management of perioperative anemia, 100 women requiring major gynecological surgery with iron deficiency anemia who were given, again the hemoglobin rise was almost 2 to 3 at 3 weeks. So that is also again a very good thing available. So every time we don't have to rush for the blood and transfusion or PC transfusion. When we have a patient and a well advanced in our hand, we can give it and have a better idea of correcting without giving her blood transfusion. So to conclude, it is a superior to oral iron when we talk about FCM or other IV irons in terms of speed of giving it. Absolute no hypersensitivity, no test doses required. And also the global studies and evidence support that there is a rapid increase in hemoglobin within, say, 20 days. So it can be administered to all the pregnant patients in 2nd and 3rd trimester more convincingly, because there is no neonatal adverse outcome, and it should be preferred IV iron in management of postpartum period when we are talking about the gynecological surgery and the perioperative anemia. So I think, thank you. This was a very comprehensive approach and a short data, which I am happy to present in front of you. We have our chairpersons, Dr. Reshmi Banerjee and Dr. Beenal is there, Kavita ma'am is there. I would all invite for sharing the live experience with iron carboxy maltose. As I already said, I'm very convinced. I'm giving in perioperative phase. I'm also giving in the preoperative phase when you are planning a vaginal or the abdominal hysterectomy. And when I have got time where I can save a blood transfusion, it's a very good idea of giving this. So any comments from Bapat Madam, most welcome, and from Reshmi or Beenal who are there, sharing their views.
Dr. Ajinkya, anything you want to ask, or we should continue with it? You are absolutely right, Archana. I'm using him on all preoperative patients with the FCM if there is a hemoglobin is less. and I find it okay because patient gets happy कि blood transfusion नहीं लगेगा. Honestly, in the heart of heart, though sometimes it's good, and then it's had as a good result of post-operatively. And even in antenatal patients after the 24 weeks, and the thing hemoglobin is not between 7 to 10, I prefer to give FCM. And I think Dr. Beenal and Dr. Rishmi and Dolly will like to comment on it. And any questions, then I can see.
I fully agree with Archana and Kavita ma'am that, from like it has totally changed our therapy. The day we have been using carboxymaltose, probably we are now not using any other source of iron because we are very sure about the result. We are not worried about any complications, like whatsoever. We have not seen that in any patient. And, compliance is well taken care of, that we are sure that this much iron is gone. And in next 15 days, we are sure to see a result. So very promising. And as ma'am said that even patients have a reduced complaint of leg cramps and overall weakness. So even if the hemoglobin is borderline, like, let us say 10 or something, but the ferritin is low, it is a good sense of giving it because overall post-op recovery and the feeling of fatigue, that goes away after giving this iron. And even I've seen good results with the hair loss patients.
Oh.
Yeah.
Yeah. I mean, this is one of the most, it also avoids with iron sucrose, the multiple visits were required. So this is a single dose. So multiple visits can be avoided. The painful intramuscular injections can be avoided. And for me as a clinician, most important is that I'm ensured that this much iron has gone in. So and patients especially who are intolerant to taking iron. And for pre-op patients, mainly those who are intolerant to taking oral iron. So in that I prefer FCM. And those who are hemodynamically stable and with a low hemoglobin, FCM is an excellent alternative, and also saves blood products for patients who are not hemodynamically stable, for emergency, trauma, accident patients, and especially for thalassemia, because I work in an institute where we have a free thalassemia transfusion center. So I know how much they struggle, for the thalassemia babies, for patients, like during COVID times, to get blood for them. So it saves important blood products. We can even make do with blood components post-operatively. If their hemoglobin is good, but they have just some oozing or bleeding, INR is high, we can just give them FFPs and, tide over the crisis and save some blood products. So excellent product. So I would really, thank the people who did the initial research, R&D. They are the ones we should be really thankful to. Gives us a good night's sleep, all of us.
Dolly, you're working with the government setup. Any words from you? Because I think we have got a class.
Is it available? I know another thing I would like to mention. Many people initially they would say it's so expensive, madam. Kitna महंगा. So I just give them, some mathematics. See, if you take tablets, for 1 month, therapy would cost you so much. And this is a total dose, and you've not taken tablets for many days, or those who are not tolerant, So when you explain to them, or I think in government setup only iron sucrose is available in Gujarat. I'm not sure about FCM.
No, ma'am, we have FCM available. We have stopped
FCM available. Oh, that is good then, yes. Because last I knew was only iron sucrose available. So, but then cost factor also comes down, because when you calculate taking daily oral iron, which they have not taken, or those are not tolerant, overall it gives a good results.
Right, ma'am. We have switched over to iron, this FCM, ma'am.
Yeah, FCM is better. And with availability of 1K, I think it becomes more easier for us to understand and get a better price.
Both the strengths available. We have 500 milligram and 1000 milligram. Both the strengths available in our this government setup.
Good.
And one thing Dr. Chelappan wants to ask that.
Yes, ma'am. We have few more questions, ma'am. We have few more questions in the chat box. Shall we take it?
Yeah. Dr. Chelappan is asking that have you experienced any side effects in the peri-operation state? I think I have not because we give well in advance or either I give in the post-operative period. Intra-operative I have not given. I have given pre-operative and post-operative. I think I have nothing to share like that. And
sometimes I don't want to discuss some little itching kabhi bolte, but that's so less. So not to discuss sort of. Very less itching sort of.
Yeah. Anything else, Dolly, you can put?
Yes, ma'am. One more question. In peri-operative period, What are the indications for blood transfusion, and when can IV iron can be used?
It's for the common question. If it is like the perioperative situation, again, same I'm saying. If the hemoglobin is less than 7 by my criteria as well as every criteria, I'll tell patients that during the surgery, but between the 7 to 10, I prefer giving the FCM sort of thing so that the patients are also happy, I am also happy, and we can do the things is important. But if it's less than 7, we always prefer doing blood transfusion. Am I right? Me, Binal, Archana, Rishma?
Yes, ma'am.
Yes, yes.
Yes, when you have got a window period, you should always act. And FCM is a promising thing which is there. But when the patient is received not in a window period, we have to just go ahead with the delivery. Then blood products and blood PCV becomes a better promising this thing. I think Dr. Chelapan has put
Yes, ma'am. Next
different
question is
rise of hemoglobin per week between oral iron and iron sucrose. Definitely, there is.
There is. Am I right?
I said within 20 days, you can experience a rise of almost 3 to 5. So that is a good promising thing. Oral, if you give for, say, a regular period of 3 months, I mean, 2 or 3 grams you will get after a compliant patient who's taking for 3 months daily iron. I mean, anybody wants to share anything else?
Reticulocyte count is so important. Just try to check the reticulocyte. Though we don't do it. But if you have the reticulocyte count kiya after giving the FCM, it's definitely, we can see the rise in 2 weeks. So it's another important thing. So in comparison to oral or the sucrose, we find with more reticulocyte improvement with FCM.
Yes, madam is talking about that it is not only correcting anemia, but it is also increasing the iron stores also. So we are giving a patient a better quality of life, not just today and later on also. As Bina also highlighted, restless leg syndrome, sometimes hair loss, these are so things. I mean, we are very much bothered as a female. So I feel we are giving good quality of life to the patient later.
Yeah, ma'am, next question. Can intravenous iron given in late pregnancy, or it should be reserved only for the postpartum period?
No, late pregnancy, as madam already said, when you have a patient in the window period, anywhere between 7 months to 8 months, you can always go ahead with that.
Up to 34 to up to 35 weeks, I think we all are giving. Am I right? 35 weeks.
Yes, ma'am.
And again, the criteria,
35 weeks.
Yeah, criteria is same, 7 to 10. Means what I always feel, if 7 se kam hai, to then the things always become. I think Dr. Chelapan join kyun nahi hote itte question pooch rahe? Where is he?
He's there,
Chelapan,
the delegate link actually.
Chelapan is actually a delegate, and he was my senior in the medical college and extremely.
He's a very sincere person.
Very sincere person. I mean, Chelapan, you are sure you're listening to me. I remember all the peripheral smears you made me look into in the labor room.
Very sincere person.
But he's a very good concept. Kavita ma'am, उनको पूरा concept है जो peripheral जो हम smear लेते हैं. We had invited him in Baroda and he had taken a very good talk. I mean, Dr. Ajinkya, you can rope him sometime in your talks during when you're talking
Barul Society.
Excellent on that.
Yeah, he's with Barul Society. But an alumni of Baroda Medical College.
I know, he came to me.
Sir wants to know that what is the present cost of 1000 milligram FCM?
That Ajinkya will give the answer.
Amardeep ji, you want to take this question?
Ma'am, we have both strengths 500 and 1K. 500 is around 2600. It will be offered to the patient. MRP is although 3200. And for 1K, it is around 5500, which is the MRP.
Thank you, Amardeep. Ma'am, one more last question. Is it safe to use FCM in menorrhagia in teenage girls?
Absolutely.
Yes.
Absolutely. Exclude few things. Do ferritinine, serum ferritinine, give the FCM. That's the best one can give.
So, ma'am, that's it. We have answered all the questions, ma'am.
So thank you so much, I think, Dr. Archana, Binal and everyone. And thank you, Amardeep ji and Ajinkya for Emcure.
Thanks a lot, ma'am. Always you are there. Thanks a lot, ma'am. Thanks a lot.
Thank you, ma'am. Thank you.
Thank you, Archana, ma'am. Thank you, Binal, ma'am.
I think we were in time and we are leaving the program in time. That's the best thing.
Yes.
7
Thank you,
o'clock
Rashmi.
को start किया, 8 o'clock को खत्म.
Thank you. Thank you.
Thank you, Dolly.
Ma'am,
Bye.
we had around
you, ma'am. Good
90,
night, ma'am.
around 90 participants which were online.
Good,
and on
good.
YouTube.
Appreciable, appreciable.
Hemal बस एक ही मिनट hold.
Mostly from Gujarat and MP, and others also from Jammu, and we had from South all some participants.
Good.
In fact, from Maharashtra too.
Maharashtra also.
Wow.
Good, good. Thank you so much.
Thank you.
Thank you.
May I invite Dr. Ajinkya to give the vote of thanks?
Yes.
Thank you, Dr. Dolly. Once again, I would like to thank all our esteemed faculty for such a wonderful presentation and discussion on the operative procedures and anemia management. I, along with my teammates and the entire Emcure, once again, thank you from the bottom of our hearts to continue giving us your support. And we hope that the discussions and these sessions help us in sending the benefits of FCM to the maximum population. Once again, on behalf of Emcure, I thank you all the faculty, and I would also like to thank all the participants who joined in this session today and stayed us with till the end. Thank you once again.
Thank you so much.
Bye.
Thank you,
Good
ma'am.
night.
Thank you.
Good
Bye,
Thanks a
ma'am.
lot,
Good
ma'am.
night.
Thanks a lot, one and all.